speakers, Dr. Hussain Abadin, MD, MPH, FCS. Dr. Shabir is a board-certified endocrine and general surgeon. He specializes in advanced procedures including thyroid, parathyroid, and adrenal surgery, as well as robotic surgery. His extensive clinical background includes a role as endocrine trauma surgeon at OSF St. Anthony and Progressive Surgical Associates. Sir, please.
Good morning, everybody. Thank you for coming. I want to talk a little bit about thyroid disease, and specifically with an audience. I know we have medical students here, registrars, house staff, speaking to the surgical aspect of thyroid care. Thyroid, as you know, if you work with endocrinologists or medical doctors, they can talk about thyroid physiology for hours and hours, but we're going to truly try to focus on the surgical aspects of care. So a little bit of a lecture outline so you have an idea of what we're going to be talking about. We'll talk a bit about anatomy and histology, what's relevant for a surgeon, thyroid hormones, understanding the physiology to the extent of being able to replace it effectively in cancer cases, non-cancer cases, hypothyroidism, hyperthyroidism, workup of a thyroid mass, cancer management. I understand you have 2 thyroid cancers on surface right now, so we can talk about those cases if you'd like as well. And then surgical approaches. You know, I usually do conventional thyroidectomy, but I'm familiar with and work with colleagues who do remote access thyroidectomy, so we can talk a little bit about that and what those approaches are. So this is a Netter diagram of the neck, of the muscle layers in the neck, relevant anatomy in thyroid. So this is mostly for students, I imagine. The strap muscles in the neck. If you haven't seen a thyroid before, let's see if this is. So these are the strap muscles in the neck, the anterior strap muscles. So these are very relevant when we're doing our operation for conventional thyroidectomy. We make your cervical collar incision, going through the platysma, entering through the midline raphe, and entering the thyroid compartment. If you have metastatic disease and you're doing lateral neck dissections, the sternocleidomastoid and the omohyoid become very relevant because these are demarcations for levels of lymph nodes in terms of assigning regions for regional disease. 2, 3, and 4 are usually in this area. Level 1, which is rare to be involved in thyroid cancer, and then level 5 in the posterior neck region. These are relevant for understanding mostly nodal distribution. Arterial anatomy. So this is the thyroid right here. The relevant thyroid arterial anatomy is superior thyroid artery, usually coming from our external carotid artery. I usually mention this because at least I use typically an energy device to take down our superior pole as kind of our first part of the operation.